The deadliest part of a heart attack often happens before the diagnosis is made, because long before doctors see an ECG, long before blood tests become positive, the heart muscle is already fighting for survival. Acute coronary syndrome, often abbreviated as ACS, is one of the most important topics in cardiology and emergency medicine. It represents a spectrum of conditions caused by a sudden reduction of blood flow to the heart muscle. This reduction in blood flow deprives cardiac tissue of oxygen and nutrients, placing the myocardium at risk of injury and death. Now, this is where many students become confused. Many people think acute coronary syndrome is a single disease. It is not. Acute coronary syndrome is an umbrella term that includes three closely related conditions: unstable angina, non-ST elevation myocardial infarction, commonly called NSTEMI, and ST elevation myocardial infarction, known as STEMI. Although these conditions differ in severity, they all originate from the same underlying pathological process. And once you understand that process, the entire topic becomes much easier. Today, we are going to build this understanding step by step, beginning from normal coronary circulation and progressing all the way to diagnosis, treatment, complications, nursing management, and examination pearls. Before discussing disease, we must first understand normal physiology. The heart is a muscular pump that works continuously throughout life. Unlike many organs that can rest periodically, the heart contracts every second of every day. Because of this enormous workload, the myocardium requires a constant supply of oxygen-rich blood. This blood is delivered through the coronary arteries. The two major coronary arteries are the right coronary artery and the left coronary artery. The left coronary artery further divides into important branches, including the left anterior descending artery and the circumflex artery. Under normal conditions, these vessels remain open, allowing oxygen and nutrients to reach every cardiac muscle cell. As long as oxygen demand and oxygen supply remain balanced, the myocardium functions normally. Problems begin when supply can no longer meet demand. And that is exactly what happens in acute coronary syndrome. Acute coronary syndrome does not suddenly appear overnight. In most patients, the process begins years or even decades earlier through a condition called atherosclerosis. Atherosclerosis involves the gradual accumulation of cholesterol, lipids, inflammatory cells, and fibrous tissue within the walls of arteries. Over time, these deposits form structures known as atherosclerotic plaques. Initially, these plaques may not cause symptoms. A person can feel completely healthy while plaque silently accumulates within the coronary arteries. This is why cardiovascular disease is often called a silent killer. The danger is not simply the presence of plaque. The real danger occurs when the plaque becomes unstable. And this is where acute coronary syndrome truly begins. Pay close attention here because this is the core concept that explains everything else. An atherosclerotic plaque consists of a lipid-rich center covered by a fibrous cap. If this fibrous cap becomes weak, it can rupture. The moment rupture occurs, the body interprets it as vascular injury. Platelets rapidly rush to the site. Clotting factors become activated. A thrombus begins forming. What started as a microscopic rupture now becomes a growing blood clot. This clot partially or completely obstructs blood flow through the coronary artery. The downstream myocardium suddenly receives less oxygen. The heart muscle becomes ischemic. If ischemia persists long enough, myocardial cells begin dying. This sequence can be summarized as plaque rupture, platelet activation, thrombus formation, coronary artery obstruction, myocardial ischemia, myocardial infarction, cell death. Everything in acute coronary syndrome originates from this cascade. The severity of obstruction determines which form of ACS develops. If the clot causes only partial obstruction and no myocardial cell death occurs, the patient develops unstable angina. If myocardial injury occurs but the artery is not completely occluded, the patient develops NSTEMI. If the artery becomes completely blocked and extensive myocardial necrosis develops, the patient develops STEMI. Think of these as different stages along the same disease continuum. The underlying pathology is similar. The extent of myocardial damage differs. Unstable angina represents myocardial ischemia without detectable myocardial necrosis. The patient experiences chest pain because oxygen delivery is inadequate. However, heart muscle cells have not yet died. This means cardiac biomarkers remain normal. Clinically, patients often report chest discomfort occurring at rest, increasing frequency of angina episodes, or pain that is more severe than usual. This condition is particularly dangerous because it serves as a warning sign that a myocardial infarction may be imminent. NSTEMI occurs when ischemia progresses far enough to injure myocardial cells. As cardiac muscle cells become damaged, intracellular proteins leak into the bloodstream. One of the most important biomarkers released is cardiac troponin. Unlike unstable angina, NSTEMI produces elevated cardiac biomarkers. However, complete transmural infarction has not yet occurred. The ECG typically lacks the classic ST segment elevation seen in STEMI. Instead, clinicians may observe ST depression or T-wave inversion. Now we reach the most severe form of acute coronary syndrome. STEMI occurs when a coronary artery becomes completely occluded. Blood flow abruptly stops. Large portions of myocardium become deprived of oxygen. Within minutes, irreversible cellular injury begins. If reperfusion is not achieved rapidly, extensive myocardial necrosis develops. This is why cardiologists often say, time is muscle. Every minute of delay means additional heart muscle dies. The hallmark ECG finding is ST segment elevation. This elevation reflects severe transmural myocardial injury. STEMI is a true medical emergency requiring immediate reperfusion therapy. Imagine a patient arriving in the emergency department. The most common symptom is chest pain or chest pressure. Patients often describe a crushing, squeezing, heavy, tight, or pressure-like sensation behind the sternum. The discomfort may radiate to the left arm, both arms, neck, jaw, shoulder, or back. Many patients experience shortness of breath because the heart's pumping efficiency becomes impaired. Others present with sweating, nausea, vomiting, dizziness, anxiety, weakness, or palpitations. An important examination pearl is that not all patients present classically. Women, older adults, and patients with diabetes may present with atypical symptoms such as fatigue, indigestion-like discomfort, nausea, or unexplained breathlessness. This frequently contributes to delayed diagnosis. Diagnosis relies on three major pillars. First is the clinical history. Second is the ECG. Third is cardiac biomarkers. The ECG should ideally be obtained within 10 minutes of patient arrival. In STEMI, ST segment elevation may be present. NSTEMI often shows ST depression or T-wave inversion. Unstable angina may produce transient ECG changes or even a normal ECG. Cardiac troponins are among the most sensitive indicators of myocardial injury. Elevated troponins strongly suggests myocardial infarction. Serial measurements are often performed because levels may initially be normal before rising. The primary goal is restoring myocardial oxygen supply while reducing oxygen demand. Patients are monitored continuously. Supplemental oxygen may be administered if oxygen saturation is low. Antiplatelet therapy is crucial. Drugs such as aspirin reduce platelet aggregation and limit clot progression. Additional antiplatelet agents may also be administered depending on the clinical situation. Anticoagulants help prevent further thrombus formation. Nitroglycerin may be used to reduce myocardial oxygen demand and relieve ischemic chest pain. Pain control is important because severe pain increases sympathetic elation and cardiac workload. If this explanation is helping you connect unstable angina, NSTEMI, and STEMI as one continuous disease process, take a moment to like the video and subscribe to EliteMedicNexus. Understanding cardiology becomes much easier when you understand the underlying mechanisms rather than memorizing isolated facts. For STEMI, restoring blood flow rapidly is the highest priority. The preferred method is percutaneous coronary intervention, commonly known as PCI. During PCI, a catheter is advanced into the coronary arteries. The blockage is identified, and blood flow is restored, often with stent placement. When PCI is unavailable within the recommended timeframe, thrombolytic therapy may be considered in appropriate patients. The goal is simple: open the artery, restore perfusion, save myocardium. ACS can produce numerous life-threatening complications. Damaged myocardium may trigger dangerous arrhythmias. Ventricular fibrillation remains one of the leading causes of sudden cardiac death following myocardial infarction. Pump failure may lead to cardiogenic shock. Heart failure can develop when large areas of myocardium become dysfunctional. Mechanical complications such as papillary muscle rupture, ventricular septal rupture, or free wall rupture may occur. Although less common, these complications carry extremely high mortality. Nurses play a critical role in the management of acute coronary syndrome. Continuous monitoring of vital signs and cardiac rhythm is essential. Chest pain should be assessed frequently using appropriate pain assessment tools. Electrocardiographic changes must be recognized promptly and reported immediately. Medication administration requires careful monitoring to ensure therapeutic effectiveness and identify adverse effects. Patient anxiety should be addressed because fear and stress can increase sympathetic activity and myocardial workload. Patient education is equally important. Patients must understand risk factor modification, medication adherence, dietary recommendations, smoking cessation, exercise guidelines, and follow-up care. The best treatment for ACS is preventing it from occurring. Major modifiable risk factors include smoking, hypertension, diabetes mellitus, obesity, dyslipidemia, physical inactivity, and unhealthy dietary habits. Controlling these factors significantly reduces cardiovascular risk. This is where medicine shifts from treatment to prevention, and prevention remains one of the most powerful tools in cardiovascular care. For examination purposes, remember these key concepts. Acute coronary syndrome is an umbrella term that includes unstable angina, NSTEMI, and STEMI. Unstable angina causes ischemia without myocardial necrosis. NSTEMI causes myocardial necrosis with elevated troponin but no ST elevation. STEMI causes complete coronary occlusion with ST segment elevation and extensive myocardial injury. Troponin is one of the most important biomarkers of myocardial infarction. Time-sensitive reperfusion therapy is critical in STEMI management. And always remember the pathophysiological sequence: plaque rupturation, thrombus formation, coronary occlusion, ischemia, infarction. Many examination questions can be solved simply by understanding this sequence. Acute coronary syndrome is not a single disease, but a spectrum of conditions resulting from sudden reduction of coronary blood flow. Whether it presents as unstable angina, NSTEMI, or STEMI, the underlying process usually begins with atherosclerotic plaque rupture and thrombus formation. Understanding how coronary obstruction progresses to ischemia, myocardial injury, and ultimately myocardial infarction allows clinicians to recognize symptoms early, diagnose accurately, and intervene rapidly. In clinical practice, every minute matters, because every minute of untreated ischemia can mean additional heart muscle lost forever. If you found this lesson valuable, save it for revision, share it with classmates and colleagues, and subscribe to EliteMedicNexus for more deep clinical explanations that transform complex medical topics into concepts you can truly understand. Unstable angina explained, from plaque rupture to chest pain. STEMI versus NSTEMI, the complete clinical and ECG comparison. Thank you for learning with EliteMedicNexus. Keep studying, keep questioning, and keep building the clinical reasoning skills that turn knowledge into excellent patient care.